All right, so we are recording. Welcome to SPA's speaker series, and we have Dr. Ainat Rogel. She's presenting on incorporating biofeedback, neurofeedback with psychotherapy to treat people with developmental trauma. And Dr. Rogel is the founder and director of Boston Neurodynamics. She currently serves as the president of ISNR, which is the International Society for Neuroregulation and Research. She has a PhD in computer science and neurobiology and an MSW in social work. She's a licensed independent clinical social worker and a BCIA certified neurofeedback provider and supervisor. Dr. Rogel advocates for incorporating neurofeedback and biofeedback as part of therapy in general. And she also believes in fundamental and large-scale research studies and is very willing to help with SABRC students on their journeys and encourage you to reach out to her. Dr. Rogel, you have the floor.
Thank you. And thank you, everybody. So yes, please feel free to ask questions. I cannot see the chatting, and I also cannot see if people raise their virtual hand. So Rebecca, you're going to monitor it. Wonderful. So the way that I would like to start this presentation is actually with the summary, which is actually a spoiler. And for all the people who will, stay for a short time and then we'll have to leave, maybe we can repeat it at the end after we will really understand what is going on there. So neurofeedback and biofeedback are effective tools in treating people with developmental trauma. And this, we see it in research, and we also see it on a daily basis in our clinic. So I am specializing with people with developmental trauma, with dissociation, with trauma in general. The reason that I would say that it's effective because it allows people to get to places that were too overwhelming. And these were all the times that were, going in circle, talking about the symptoms, not able to get to the core of the problems. And that's what is neurofeedback doing. It treats the source of it. It treats the limbic system and the fear brain rather than the many symptoms that they have. Neurofeedback is part of comprehensive approach, which means there's only one modality. And the whole treatment should include also therapy for recreating the narrative, for a lot about psychoeducation and validation about what the people are dealing with or what is going on with them. And it's a complementary modality for it. It's also, we work a lot with the body because the body also holds a lot of memories. There are many ways of working with the body, so I'm not really going between different ways, but in general, nutrition, which is important thing, and sleep, which we also know that people with trauma are struggling a lot with it. Okay. I would also talk about the proactive approach of the practitioner, whether biofeedback or neurofeedback in the treatment. We always have to assess safety. It's not hard to recall memories, to gain memories, or to deal with what is going on. The hard thing is when these things are happening, we would like the people to feel safe. We would like them to process them, and also we would like them to move on after processing them in the right way. Also, we would like to talk about tracking unintended reactions, or some people would say side effect, some people would disagree to the phrase of side effect, but like every other condition, neurofeedback and biofeedback have side effects. And it's our role to track it. It's not the client's role. Now, in the treatment itself, we need to know our clients. We need to know the specific individual background. We need to know the impact of a developmental trauma. which means the impact on the brain, the impact on the body, the impact of the medical conditions. We also would like to know the presenting symptoms and the source of the problem, and keep going back and forth between them. We also want to gather the whole neurophysiological system level. When we do the treatment, we use not only neurofeedback or not only one specific modality. We train one modality, which could be neurofeedback, or it could be heart rate or respiration, and we monitor the rest of them. And you would see, especially with people with developmental trauma, that you train one modality and it works really well, but then you see that all the other systems there, physiological systems, are getting out of wacky. Like the EEG is getting better, but then you will see the breathing is getting really fast and shallow, and the heart rate is almost flat. Temperature is not all the time going hand in hand with a galvanic response, which is the sweatiness, and muscle tension, tons and tons of it. So we always would like to get the whole picture of it. And the last thing is the importance of research, both of efficacy that we can advocate for it, and the knowledge of understanding what's going on and educating our client. Okay, so this is the presentation. Now let's start walking step by step to get to how we actually make all this sense for this summary. So we're going to start with the motivation, if this was not enough. And the next, we're going to talk about terminology, because I would like to make sure that we're all in the same base about when I'm talking about trauma, developmental trauma, and PTSD. Then we're going to talk about the impact of developmental trauma, then research, and then in the clinic. So when you talked about the ratio of neurobiofeedback versus the whole picture, well, you can see where it is here. But I still want to make sure that we will have enough time to talk about how we implement it in the clinic. So let's start with motivation. I'm going to read the green lines over here. And the idea, this is a mother of a child who participated in the child study that we did as part of the trauma center. And this was to see the impact of neurofeedback on children with developmental trauma. Now, this mother really got what neurofeedback was doing. This child, he was 12, almost 13, and we were debating if to include him or not, because he started puberty. And then we were talking about kids who were 6 years old. And it's hard to get a homogeneous group when we talk about such age differences. The reason that we accepted him, because he was doing very poorly, and it was obvious that it's going to be either the neurofeedback or he will have to go to residential program. One of the main things that we can see here is just to start getting the idea, what are these kids are suffering from? They're not suffering from the flashbacks. They're not suffering from re-experiencing. This happened when they were, very little, or might not. But what the mother was talking, being in school was a nightmare, as he was denied all field trips, sitting in the lunchroom, art classes, etc., because his little feet and hands were unable to keep still. This is what we see with the kids with developmental trauma. My son's journey has been a rocky one, filled with deep waters, swamps, and at times quicksand. Once we added neurofeedback to his life in a consistent way, new pathways have been forged in his brain. Long story short, he does not need the impulsive behaviors because he has new pathways that afford him a few deep breaths and the chance to use one of the many healthy coping skills he has learned through the years. Those survival pathways served him extremely well when he needed them. But now that he's safe, will only provide him negative consequences, detrimental impulse choices, damaging relationship, job opportunities, and even himself, and will only lead him to places of no growth or opportunities. So when the mother was talking about it, this child, we knew when he's coming to the trauma center because he knocked down all the garbage cans on the way. He was banging on everything. He was not knocking on the door, but, kicking the doors. We heard when he was coming. And what she got from it, and she understood from also the psychoeducation, is that neurofeedback is making the brain safe. It means it calms down the limbic system. And now it's not only that he has all these many coping skills that he gathered throughout the years. He could have told me all these coping skills, like, just list them, 1, 2, 3, 4, 5, 6, whatever. But he was not able to implement it. Once he was safe and he did the neurofeedback, he was able to go back to his executive functioning, remember this coping skill, use it, and then calm down in a different way than this reactivity that happened before. So as a first-hand observer and an ever-present mama bear, I implore to you all that neurofeedback is your loved one's pathway to hope and a lifetime of freedom. So this is our $1 million questions. Are they beneficial to treat trauma and developmental trauma? So biofeedback and neurofeedback, they help with these challenges. They treat the source of the problem, the neurophysiology, the brain, the body, the physiology of it. They're validating rather than pathologizing. When we show somebody the brain mapping, they see what is going on in the brain. We don't have to talk about diagnostic. We're talking about validation. If this is your brain, active limbic system and not functioning executive lobe, well, yeah, you will first react, then you will be sorry because you will know that it's the wrong thing to do. It's relatively fast impact. So 30 years of talking therapy can be shrinking to 3 months or maybe a little bit more, but it looks good to keep the 3 on them with neurofeedback. Was shown to be effective when other treatment failed. And we often see it both in the studies that we did and also in the clinic. And this is like, well, I've tried everything else and this is the only hope that I have at this point. I am treatment resistant, I failed everything, I cannot do anything else that other people are doing, like what's wrong with me? And this is okay, and sometimes they're coming, well, if you're not going to help me, I'm going to kill myself. Oh, this is a little bit worse, but it did not happen. Now, it's not a magic wand, it's a proactive approach and it needs to be incorporated with other treatment modalities. We would never, ever, ever do neurofeedback and biofeedback without therapy. Oh, sorry. So next, let's go to terminology. This is one of these definitions of trauma, which I always have a hard time to read it out loud because it's one sentence paragraph. So the idea is that its trauma is a result of events that were harmful and were perceived as harmful or life-threatening to the person. And these events could be physical, social, emotional, neglect also, or spiritual well-being. So not everybody who has trauma would develop PTSD. PTSD is a diagnostic. And originally it was for people who came back from the Vietnamese War, although the term of shell shock was used before. And the idea is that the soldiers who came back from Vietnam War, they were not the same people who started it. So this is what was happening to them, is the trauma that caused the long-term impact that their life or the way that they lived were not the same as before. So with PTSD, we have the time before that many of them, had, life without trauma. there was something really bad that happened. And by the way, I just read an article about this picture, which I did not know, about this girl who they took the picture. She lives now in Canada, and she started a funding for children and people who are suffering from trauma. It's very interesting to hear about it. She is from Vietnam. And then after the trauma was happening, their life after the trauma were not the same. They were still stuck in the trauma and they were not able to move on. Now, developmental trauma is not trauma and is not, well, it's sort of like part of a trauma, very specific trauma, but we would not consider it as an event related. And what we call it, it's the elephant in the room. And Felipe, we will talk a little bit more about him. It's about traumatic experiences are often lost in time and concealed by shame, secrecy, and social taboo. It's there, but nobody's talking about it. It's more likely about, oh, now you have the depression, anxiety, bipolar, schizophrenia, ADHD, whatever, not mentioning the personality disorder, we will deal with this. But what happened to you as a child happened to you as a child. Let's move on. So what is developmental trauma? It's a chronic exposure to violence, abuse, and or neglect in early ages. And this is Bessel van der Kolk, who already talked about it in 2005. Why is it important? Because it's arguably the most costly public health challenge in the United States. And even now with the COVID, the developmental trauma plays a huge role in it. About also how people are, dealing with the trauma with the COVID and what's the impact of it. And how it has negative impact on well-being, mental and neuronal development. And it has impact throughout the life, not only as children. So let's talk about this impact of developmental trauma. So we see, this is how a little child or toddler should look like: happy, funny, enjoy, know that this little boy is the most precious thing to his father, to his caregivers, to the mothers, to everybody that they see. But that's not the case in developmental trauma. You will not see kids with developmental trauma that they're laughing. When I see the pictures of people when they're young, you see the face, and it's so hard to see it because it's blank. There's no happiness there. It's already, the brain is in a danger mode. And that's what happened to the children that are ending up, sadly, like this. Not all of them, but many of them on the street. So the first study that talked about it was the ACEs study, Adverse Childhood Experience. It was at the end of the last century, I can say. And that's the first time that adverse childhood experiences were correlated with long life implication and impact. And it shows what is going on, what is the effect of it. Disturbed neurodevelopment, social emotion, cognitive impairment, adoption of health risk behavior, diseases, disability, and social problems, and early death. Now, this study was done in California, in Kaiser, and since then it's only a history of that's what we know. Now, people with developmental trauma, you will not see them in the psych units, usually. You will see them with a high blood pressure, in the cardiology, in the allergy department, in the GI units, in the kidneys with dialysis, and a lot of other medical issues that they have because of being in such chronic stress all their life. So another way of talking about it is about child maltreatment. And Marty Teicher, who I also highly recommend to read his papers, also often calls it child maltreatment, is a severe stressor that produces a cascade of physiological, neurochemicals, and hormonal changes, which can lead to enduring alteration in brain structure and brain functioning. So we know this for a long, long time. I'm not going to show the research, but the summary of it is that it causes, like DT, developmental trauma, causes excessive activity of the limbic system, reduced activity of the frontal lobe. And if we know that the frontal lobe, one of its role is to inhibit the limbic system, it's failing to do it. It's also compromising the executive functioning, cognitive, behavioral, and emotion regulation. So people are not in a good place like this. Limbic system is active 24/7, and there's nothing, I mean, that like the executive functioning is pretty compromising in all these roles that it has to do. There's also an issue about impact connectivity between brain areas. Either it's a lot of it if it's connected to the danger brain, or it's compromised when it's connected, for example, to the front back. Front is executive functioning, back is limbic system. This can let us know that the effectiveness of talk therapy may be reduced due to overwhelming subcortical emotion dysregulation arising in the nonverbal hemisphere, or even not in the even in the verbal hemisphere. And the idea is that the talking therapy, like I will call him David, the child that the mother gave the testimony, he knew all these things. He could not apply them because the limbic system is faster than the frontal lobe. So it first goes to the danger brain reactivity, and then it goes to the frontal lobe, and then it's like regret. Why did I do it? Yes, I know all these skills. And I apologize for people who are doing a lot of CBT, and they are important, and people need, like, we cannot compromise with, like behavioral of breaking and doing all these things, but we need more than this. It's important to know it, but we need more than this. We need to treat the source of the issue, which is the active limbic system. Okay, so when we talk about the autonomic physiological activities, we're talking about dysregulation, and both in limited flexibility in responding to the environment and difficulty recovering from stressors. And we see it very much when we do a stress test, like physiological stress test. We see it, like even after there's one stress, it takes them such a long time to recover from it. Frequent muscle tension. And one of the kids also that we saw, he used to tell us, after he finally was able to realize that his baseline is a lot of muscle tension. And he said, finally I get it. He was 8 years old. I used to be like a raw spaghetti. Now I feel like I'm a cooked spaghetti. And now I can understand the difference of it. Breathing, shallow breathing, over breathing, sometimes holding breathing, but not like what we expect. Heart rate variability, very low, low peripheral temperature, high skin conductivity, and again, synchronization between these parameters, not really there. Even if one system is doing the right thing and is relaxing, right? The other system would go and kick in, and it's not doing well. We do a lot of assessments, and I'll talk about it in the clinical part. And when you look at it, we can see temporals, a lot of temporals activity here, lots of slow activities. You can see that there's a bump here in the alpha range and also some in the high beta, which is not really muscle tension because it goes down toward the end. So temporal activity is excessive, is common, also parietal can be there, and we will see more of it. So here you can see, well, I wouldn't say typical, but one of many QEEG. Now, can I say QEEG, or I have to define what is QEEG?
I believe you can say QEEG. You might briefly just say it's kind of like the
So
I don't know if there's a few people here I don't know. So
okay. So QEEG is quantitative EEG, which means when I measure for assessment the brain activity from like let's say 19 location in a standard location, then we do a special analysis which is quantitative, and it moves the activity from the time domain, the way that we record it, to the frequency domain. So what I see here is compare the individual brain activity to norm values, and you can see here the units which are in standard deviation, and the warm colors, yellow, orange, red, are above the norm, the blues are below the norm. Now, each of these head is one frequency. So I start from the very slow activity all the way to the fast activities. So you can see here, yeah, in the beginning, like the slow ones, we can see blues, but you can see that mainly it's red. And again, you can see here the 19 locations on the brain, and you can see that it's mainly almost everything is red over here. The activities here are a lot in the alpha, which is supposed to be calm and relaxed. So somebody who has too much of it is actually very anxious and cannot be calm and relaxed. We know that to get the advantage or the benefit of an activity, we have to get it just right. If it's too little or too much, it's not beneficial, and it can cost, you know, like it can result with not great functionality. So we can see here, we have the limbic part, which is here at the back of the head, and the temporals. Right? We have the default mode network, which is really, really important. It's the mohawk, we say here in the middle of the head here, also overactive. We have the frontal lobe, which is also overactive, so it cannot really do anything, and the sensory motor strip, which not great relationship with the body also, and also impact a lot of attention issues. So this person is not in a great place here. We can look at a person who actually looks like a blue brain, means under the norm, right? Also, in the slow activities, which are the sleep activities, we can see really lack of activity. So sleep is being compromised a lot. But even in the other ones, we can see a lot of blue, which means that his brain cannot even put itself to get to a way that it can function well. And this person is actually very, very functional and is very good professionally, but it takes him so much amount of effort to get there because his brain cannot really produce it. And you can see here that actually one frequency in 8, which is overactive, which is pretty exception for what we see here. But for him, this one is with a lot of dissociation and not able to really calm and relax. Okay, and one of the only studies that I know about the event relation potential, which is the brain response to a cognitive stimulation, you can see what is going on. This is a norm brain, and in the event-related potential, when we do it, we repeat this experiment or this test, cognitive test, many, many times. So because the activity is so small and we need many of it to get a normal potential. So you can see that in a normal brain, you see that the brain is responding similar to every trial that they were doing. But look what is going on here with the brain of the trauma. It's just all over the place and it does not accumulate. And it's not surprising also when we see this, that most of the people with developmental trauma have attention issues. And it's not the same as the biological ADHD. It looks like similar symptoms, but the reason that it's a different, like the problem is different and it's a different networks that are involved in it, that often medications are not helpful. Okay, so next, let me see. Yep, we have a little bit of time. I'll go briefly about research, which again, we need it both to understand what's going on and to get some efficacy of what it is. So I'll talk about two research that I was involved with. And the first one with adults with developmental trauma, and the second one was with children. And they're similar in the design, so it will go pretty quickly. So again, the fast, the only slide that we want to know is that 24 neurofeedback sessions significantly reduced PTSD symptoms, according to CAPS, if people know it, but it's a questionnaire that is considered as the golden standard for PTSD, and also improve executive functioning, which was very surprising to us because we did not treat the frontal lobe. We just trained the back of the head. So the design was it was a random control trial, which is really important to have it, efficacy level 3. And it included 52 individuals with PTSD because we needed an inclusion criteria, randomly assigned to either neurofeedback or the wait list. We had 4 evaluations baseline for everybody after 6 weeks or halfway of the neurofeedback, 12 sessions, T2, post-treatment, and 1 month follow-up, which was not enough. I wish we would be able to have more budget to do a longer follow-up. Okay, so the assessments that we used was CAPS, and then we did 2 more for trauma and also for executive functioning. We had 1 protocol that we did, T4 temporal, P4 parietal, and the idea is that to calm down the active amygdala, hippocampus, the right area of the brain here. It was inhibition of 2 to 6, 22 and to 36. So slow activities and fast activities, and rewarding starting with 10 to 13 hertz, which is again, high alpha and low beta. But we always measured it and it was adjusted if needed. Twice a week for 12 weeks, for a total of 24 sessions. Now, if you're looking for protocols, this protocol showed itself. So you can already take it and start it and doing it. Okay, now, this was good, but it was still a very small sample. The problem is that we did not have a lot of funding, and it's also hard to find participants. Inclusion criteria was PTSD. And one of the main problems is that most people with developmental trauma do not meet PTSD diagnostic. And this is a big problem for us. And this was a debate about having a higher efficacy of the research or not. And, the meetings at the trauma center when we did this study and the other one is Bessel was, no, we cannot do it as PTSD because it's not fair for all the people with developmental trauma who do not have it. And then it was other people, but we need it. We can start with it and then move on, but we need it for get appreciated or valued for the study. That was always a big issue, and it's also a big compromise. I wish we would have more funding to expand it. Now, the other thing is that although it reduced the symptoms, it did not minimize it. And there is a place to reduce it more. And the question is how? Is it because it's a single protocol, it's not individual, it's not connected to the QEEG of the person, not to their symptoms. So we don't know it, but again, this is what is beautiful about science and research. Go with it. Improvement in executive functioning, I said, that was a pure surprise for us. We did not expect it. We just trained T4, P4. Not executive functioning. This is a tricky one because only 1 participant in the active treatment reported significant side effects. But I think the idea is that side effects at that time, we did not really talk about them the way that we talk about it now. And I very, very much talk about side effects. I don't hide it. It happens, and you will see more with the kids it was essential for us. So the second study that we did, we started with adults. I know that like they're older and they're already, you know, the brain was developed, they already had the coping skills, they were successful, they were upper middle class mainly. We still wanted to go back in age and also treat kids because kids, their brain is still going to develop. And hopefully by doing neurofeedback for them will help their brain to develop in a better way in the future, not only help them. And the kids, the results of the study showed that the 24 sessions reduced PTSD symptoms, again, significantly, improved executive functioning, and reduced other symptoms of trauma. Question?
Be able to continue to make YouTube videos because I know that, you know,
No, someone was just signing in.
Wow, no questions? I see like the 2 comments in the chat. Do we want to? Okay. Nope. Okay. Wow, what does it mean that everybody's falling asleep or it's so clear or what is it? But okay.
So
We're just
I had a
engaged
question.
listening.
Yes.
I had a question. How did you decide to have a group that was on a wait list versus doing a placebo neurofeedback treatment group?
So this is one of the questions we had to compromise. If we would have done placebo or sham EEG, it would be stronger. It would be even like efficacy level 4. However, I did not feel comfortable doing sham neurofeedback for kids. Their brain is, or also the adults, it's so sensitive. So sensitive. And even when you do sham neurofeedback, your brain is learning something. And I'm like, you know what? I prefer to sleep well at night and do just a wait list rather than sham neurofeedback or placebo. So yes, that was another thing that you have to, you know, scale when you design the study. I still would not feel comfortable to do sham neurofeedback with them. And the more that I work with them, the more that I see that for some of them, even 3 minutes of neurofeedback is more than enough, is not good. I am very happy about this decision, although it compromised the efficacy of the study. Any other questions? Okay. Okay. Now, this is something that I'm throwing it to you. We saw that the questionnaires show significant improvement in the subjective measurements. In the QEEG, in the individual level, nope. We were not able to get group analysis with significant differences. And one of the things that we think, it's like, you know, like the differences were different. So for example, here in absolute power, like we just measure the activity in each of these location. You can see here in the theta range was much more improved. This is a girl who was telling us that, yeah, she's in the class, she sees the teacher talking, but she doesn't really know what the teacher is talking about because it sort of like goes above her head. You can see here, this is after we do the QEEG and we move to the frequency domain. This is the EEG when we do it over time. So it's all the frequencies together. And you can see all the slow activities that she had that she doesn't really have now. Another one is, this one is also by accident, it's only theta, but we had similar ones with beta and alpha and in different locations and different frequencies. So not surprising that we did not have a group analysis. We're talking about kids with different traumas in different ages, and we saw that there was a big variabilities. Okay, I'm going to skip this one. And our observation and what we learned from it is that we need to track the changes. These kids had tons of side effects. We started with 20 minutes. We saw it was too much. We went down to 10 minutes. It took us a while because The exception, like, everybody agreed that you do neurofeedback session for 30 minutes. We did 20 minutes, much longer. When we reduced it to 6 minutes, then we started getting good results. They had side effects. They were emotional, sleep issues, behavior issues. And once we formed, a symptom checklist, that's what we did. And I'm very happy to send it to whoever who wanted it, who would like to use it. And we track it after every session. This is when we were able to see what is going on and what are the adverse reactions and the progress. Again, neurofeedback is changing the brain. We want to change it for the good, but change has both directions. The good news is when we addressed it, we adjusted the protocol and it was resolved within one session. And that's wonderful. Okay, I think I'm going to skip this one. Just one more thing that I would want to say about this study is that we wanted to gear to look for inner city children with developmental trauma. However, we ended up with most of the population as adopted children for upper middle class parents who were told by the school, it's either you do something with these kids, means you put them under drugs or medications, or we're kicking them out of school. So we ended up with these people who wanted to look for alternatives, and they came to us. Another thing is that it was 2/3 boys and 1/3 girls. So again, one of the problems, it was one protocol that we did. The large variability, both in ages, type of the trauma, ages of the trauma, large age range, all had an impact on it. Okay, so any questions until now, before we're going to get to the in clinic?
Just briefly, you mentioned that in the QEEGs, you didn't see any group analysis differences because people's baselines were so different. Did you do any follow-up group analysis using ERPs?
No, we didn't have it. And you know what? At that time, we did not even have ERPs. Now, if we're going to do it again, of course, we're going to add ERP. I mean, for me, it was the first time I ended up with, this is how I started neurofeedback. So I did not know, and also it was not so common. I learned about ERP much later, and yes, I would always do it because I see the effect of the executive functioning, yes.
A question, did you include psychotherapy at any point with the neurofeedback, or was it strictly the neurofeedback protocol?
One of the requirements for the studies, both of them, is that the people, like, the participant would have therapy. And again, therapies that they already know for a couple of months, because there were lots of things that were needed to be reflected. Like some kids talked about and talked to us, which was very interesting because they did not know us well, but they talked about suicidal ideations that they have, about gender issues that they have, about a lot of sensitive, thoughts and like feelings that they have. And this is one of the times that I want to say, yeah, I was a really great neurofeedback practitioner, and that's why they talked to me about it, or us. But the idea is that the brain felt safe. I mean, that's the takeaway that I take it, that I explain it. And when the brain feels safe, things are happening, things are being disclosed, things are getting, there. Lots of memories were revealed. People who had no memories and suddenly gained memories of, what happened to them when they were children. And we want it to be safe. So therapy is essential. We had to do some, but they all had therapists that we were always connected with, and also with the parents who were very supportive.
Okay, thank you.
Logistic questions. We have until 30 past the hour? Or how long?
How much longer were you thinking?
It says an hour and a half, but we can cut it.
Okay, I would like to save a little bit at the end just for some questions, but you're still good to go.
Yeah, okay, so no, that's what I was thinking. Okay, so all the chatting questions were answered?
Yes, they were, and everyone's commenting on how wonderful this presentation is, and we do want a copy of the symptom checklist.
Oh,
so if
awesome.
you get that to me, I can disperse it.
Of course.
And to the group. And if you don't get that in the email, email me and I'll send it to you.
Sure, great. Thank you, but now it makes the bar really high.
Yeah.
Okay, so now how do we incorporate it in the clinic? What I'm going to say here that one of the arts of neurofeedback is that there are many ways of doing neurofeedback, many different systems that are doing different things. What I'm going to talk about now is what is working for us. There are other ways that it can work, but this is what we're doing. Okay, so for all the other questions, yes, there are other methods. We know that this is working for us, so we do it, and we know that it's safe. Okay, so let's start. When somebody with trauma and developmental trauma are coming, how they're being presented, okay? Arousal, it's either hyper or hypo, not in the window, okay? Attention, they could be distracted, move all over the place, or being spacey. You know, some of the even kids, they would just sit here for the whole time, not moving, not doing anything, or, you know, they would be all over the place that the room looks after earthquake, without earthquake, like something like this. Emotion regulation and behavior regulations, 0 to 100 in no time. It's just switch, light switch, not a dimmer. We want it to be a dimmer, but it's like a light switch. Okay, quick reactivity, boom. Limbic system before executive functioning. Class, homework, all challenges, okay? Physical with others. You know, it's like one of the things is like, we don't know where this kid does not know where his hands end and where the other person starts. They're all over the place. Difficulties with coordination. That's one of the problems when you saw like the sensory motor strip that is overactive. They're not, they would say like, and it's so sad to hear it, like some of the kids like would say, you know, I know I'm always the last one to be picked for the group because I always throw the ball either too hard and then I would get out because people say that I want to hurt them, or I would throw it too too close and nobody can catch it, only the other group, and then it would cost us. And it's so sad to hear it because this is what is happening. Risky behaviors, oh yeah, they would jump to the street. It doesn't matter how many times, you know, the mothers would say, how many times I told them not to jump, and they would still do it. How many times I told them not to do this? They just don't learn it. How many times can he get burned from this fire? He still does not get it. Yes, it's sad. Binary thinking and feeling. It's either bad or good. No gray level somewhere in the middle. Academic challenges, yeah, lots of attention issues, lots of spaciness, which I would consider in most of the cases, situations, dissociation, or they just cannot concentrate. Social challenges, this is also in older ages. Intimacy, it's a big problem. Relationship with peers, parents, family, other members, work challenges, low self-esteem, and the endless list of medical issues, and all because of the chronic stress. So we don't really see here, again, the flashbacks. Yes, they do have here. They have re-experiencing, but that's not what is, you know, it affects sleep, which affects everything else. And wow, I cannot believe that I did not add sleep here. Oops. I'll add it afterwards. But these are the issues that people with developmental trauma are dealing with. Okay, Let's start with the diagnosis. First one is, again, most of them do not meet criteria for PTSD. So what can we do with it? Starts with anxiety because they're very anxious, nervous, and in fear. Okay, then depression, bipolar because they would have symptoms of manic because they don't sleep, but they don't sleep because of flashbacks, because trauma was happening at night, because the brain is overactive. Epilepsy is also often because of dissociation, it could be, and just other things. Schizophrenia, big time because of dissociation and DID, dissociative identity disorder. ADD, ADHD. I don't think I saw any client with DT who did not have at some point or another, or until now, diagnosis of ADHD or ADD. Learning disabilities, same reason. PTSD sometimes, attachment, of course. And now we're going to start with all the personality disorders, right? Which are always. Now, the problem with this, when you're starting on this, track of the medical or axis 1, like it used to be, and yes, anxiety can be treated with benzos or other anti-anxiety, depression with others. Because of these symptoms, they start having all these amazing cocktails that are not really working, and they cause side effects, but because they're not helping, they keep adding more and more. And the reason that they're not helping, because the problem is a different problems, although it's the same symptoms. And that's the main problems, similar symptoms, but different mechanism or brain activity. How I think that most of my clients were antipsychotic. Accept side effects, it did not help. Bipolar, we know that, like mood stabilizers are very good in treating bipolar. If it doesn't work, maybe it's not a bipolar, but they're still diagnosed with it. Epilepsy also, a lot of them. And we had like kids in the study who had like this kid that I gave the example, he was on 10 different medications. And I asked at some point the mother, it's like, how many psychiatrists does he have? She said, oh, 1. So I said, so why he's on 2 antidepressants, 3 anti-anxiety, all these things? Well, because they don't help and they cause, and he's worried if you will take him off it, it will just, all the balance will, get shaky and he will be in a much worse situation. So this kid has like a chemical brain there. So again, we can never, ever tell anybody to stop medications. That's not our role, but it's very sad to see it on how many medications that they are. So what are the challenges when we work with people with developmental trauma? A lack of client report. Most of it because they don't have awareness. For many of them, it's all the way up to the brain and nothing down. They don't have it. They don't know if they're happy or not happy. They don't have emotions. The baseline is like somewhere else. There's a lot of shame, a lot of secrecy and social taboo. I had like recently a social worker who one of the assessments that we do is we assess for dissociation. So we use the DES questionnaire. It's free and it's really, really important. It's not a diagnostic one, but it just gives you an idea about the dissociation. And something did not work right with me. And when I review it, after several sessions that I started working with him, and that was when I said immediately about, like dissociation and, parts and a lot of things. And then we review it. And then he said, well, of course, I'm not going to tell you about it. You're already going to stigmatize me and put me on a different direction. So of course, I'm not going to tell you anything. And this was even like to me, after a couple of sessions. So it took a couple of times and he was able to do it, but there's a lot of shame about it. Lots of crisis. Every day there's something that is going on there. it's medical emergency, it's something that is happened, it's the car is broken, a lot of things that they all make sense, but at some point you look at it, some people have so many crises that are happening every day. Therapy is stuck. They're going in circle, they're treating the symptoms, they're treating resistance, and you hear the stories from 6 years old already that they know that they're treatment resistant and they already know that they're not successful. And they would tell you this. And it's very, very sad. And it's like, you tell them, it's not you. It's like the therapy is not for you, it's for other things. And only after you do a lot of psycho-ed and again, education and validation, that's when the difference is happening. Okay, another common thing is it happened then, now we need to deal with anxiety and depression or, you know, the current symptoms. And this is even the clients that are coming. Yeah, this is what everybody was telling me and that's what I want to do. Okay, we can do it also, and let's try to do it in different ways. And that's when we do the neurofeedback, biofeedback. Now, don't tell them no, because they will never come back to you. So try to do it in a very indirect way. Okay, DT is not a diagnosis. It's actually got rejected a couple of times from the DSM. But again, the people, as we saw before, they have many other diagnoses and they were being mistreated because of this. And always the chronic stress and the medical impact of the chronic stress. So we have a lot of, again, we believe in data. We do a lot of assessment. It's important for us, it's important for the client, and it's also important to see what is going on there. We do subjective assessments, which are the questionnaires, and ACEs, again, when we talked about the pyramid of the adverse childhood experience, it's free, it's 10 questions, and it just show you, it's just a list of adverse childhood experiences that people had. More than 4 is from the 10 is a lot, is considered as a lot. And you can see even in the questionnaire how people undermined the impact of them. Dissociation we do a lot, and again, dissociation is there. You do not have to deal with it if you don't, but if you start addressing it, you will see how much more you see it. PTSD, executive functioning symptom, and then other symptoms like anxiety and depression. Now, when we talk about subjective assessment, we always talk about reliability and validation. Some of them are, some of them are not. And again, I did not talk here about names of subjective questionnaires, but some of them, again, you always want to see if they're reliable, if they're validate, what are they measuring, and also, of course, if it's free to use them or not. It's always good when they're free. Objective assessments that we do is the EEG, then we do also the Q analysis, the frequency domain, and we do now ERP all the time. And it's unbelievable how people are doing the ERP and they get phenomenal results of accuracy. Time is, it can last from really slow to really fast. But when you see the brain networks that how out of the norm they are, you really appreciate the person who was able to get such high accuracy results. It's just amazing. And there are so many of them. Okay, we always want to talk about either norm values or individual. Each of them has minuses and pluses. Norm values, when you would look at the database, I don't know how many database people ask actually for trauma. Most of them did not. So we know that when we talk about the database for the QEEG, yes, they have pluses and they have minuses. We use them, but you want to know what the pluses, what the minuses, and then to make sense of them. And the assessment to track changes between sessions. And this is the symptom checklist that we did, or even without us doing it, you can always track attention, behavior, sleep, emotions, and energy. These 5 parameters will give you a really good indication of how the neurofeedback session went. And you ask them to fill it out, or you ask them to do it the night after, so it will include the night of the neurofeedback biofeedback session. This is something that we very much appreciate. We do not hook up the client and leave the room. And one of the times, like in one of the training, one of the participants, again, who is a clinician, she said, yeah, I tried to do the alpha theta protocol. And alpha theta protocol for people with trauma, it can reveal a lot of trauma and memories. And when we asked her, so what happened? And she said, yeah, I started having, I didn't know, because the one who did it to me, he said, yeah, let's try it. He put it, the program, he left the room. And I said, what happened to you? I mean, did you feel something? What was happening? She said, yeah, I started gaining all these memories that I always wanted to forget. And what did you do when it happened? I just pushed them down. So that was missing the point of actually the alpha theta, because we want people to gain memories when they're ready, but in a safe way. And we want to be with them when they process these memories. Now, for her, she was a therapist and she was able to push it down, but I also heard about people who did it, similar situations like this. And what was happening is they just, went back there, and it was very hard for them to get out from the past. So we want to make sure it's safe when we do these things. And the other thing that we can do much better is to correlate the neurophysiological activities with the mental state. And even young kids can do, like I can tell if 6, 7 years old, can you reduce now your beta? What's going on with you? And they get it. And sometimes it's easier than adults. And when I would see, alpha around alpha range skyrocketing, like moving from 15 all the way to 60 microvolt, it's like at some point I will talk to the client. It's like, should I pause? What is going on? And this is, like when they get dissociated, for example. Or so we want them to understand what's going on. When high beta start going up, we want to ask them, have you noticed anything? Most of the time in the beginning, it will be now, what was going on? Said, okay, just look, you see the high beta went up. And then I will go to the physiological. Look what happened to your muscle tension. It went really high. I don't feel any changes. And that's also what happened because there's no awareness. Look what happened to your temperature. And now the temperature is going up, which means that they're feeling relaxed. So systems are not really working together. And I would not hide this information with them. I would talk to them. And during the neurobiofeedback, I would pause and I would talk to them about, look what is happening. And slowly, there's like always this magic moment that they get it. And this is like, this magic moment is just worth it. So another thing, I don't know if I have it or not. For example, people with physical or sexual abuse, heart rate and respiration are the hardest thing for them to do. They just can't. And so in this situation, we will do temperature sensor instead. And we will talk about it. And we'll say, I cannot breathe.
She's always the
all the
same.
way up to here.
Always
I
fun
cannot
to
breathe down.
do here.
That's what a chef does.
Hey, Beverly, could you mute your mic, please?
Huh?
Could you unmute your mic, please?
Then I can't hear you.
You can mute it. If you have host or co-host, you can just mute her. Great, thank you. Okay, what is our role in this proactive approach? To monitor changes and side effect, to empower them at the moment and after, educate, educate, and educate. It's so important. And validations of the symptoms, show them what is going on in the neurophysiological level, and also talk a lot about the impact of trauma and developmental trauma on the neurophysiology. The fear brain, we talk a lot about it. What is going on in the limbic system, in the fear brain, impact of chronic stress. Homeostasis and allostasis is, again, how systems can maintain the level. Homeostasis in the molecular level, allostasis in the system level. So when I talk about temperature and skin conductivity, that's the allostasis level. Window of tolerance, they all know it at this point. And this is, I think, one of the ways that the client learns to self-regulate with this coaching, or at least much faster. Okay, short sessions. Their brain is so sensitive. Some people I can do 3 minutes, even adult. And the rule is of the longer the session, the better it is, not working. 6 minutes average, sometimes 10. I would really not do more than 10, only with few clients who already know and they already practiced a lot. It's at least 40 sessions, but again, it's not 100 sessions of the same protocols. Protocols in the temporals are much more sensitive, and at some point you'll start getting side effects if you do it too much. When people with developmental trauma are coming to us, we said, you know what, yes, sorry, but I think 40 sessions would be a good time to start. We do 40, 50, take a break, do therapy, go to your therapist or do therapy with us, and then we can continue with it. Monitor, these are the things that we would like to monitor if you don't have, again, if you don't have the symptom checklist, sleep, attention, emotion, behavior, and energy, which is not here. Can be challenging to client and to notice and track changes. It's important for us to do it for them in the beginning. And of course, to adjust protocol. And one of the best way to do it is according to the arousal model. If the arousal is too low, and you see it based on the symptoms, you increase the reward a little bit. If the arousal is too high, then you reduce it. And it works. We don't really need fancy equipment for it. It's only knowledge. So how is our session look like? We're checking in, we're doing the biofeedback, again, with coaching and reflections, different types. Then we do the neurofeedback, both of them, again, proactive. We do therapy and more reflections or not. And then, again, we already talked about what we're all these things. And the idea is that we're contracting with the clients. Do you want me to pause? What kind of relaxation, grounding when we need it? How can we work out with one leg here in the present, one leg in the past, and always make sure that we're here and there together. And now for the people who wants always, like the recipe, which we don't have, but again, we always start with the limbic, okay, parietal temporal, and it often improves sleep, attention, and executive functioning without doing anything else, just calming down the limbic system. Right hemisphere, like the T4, P4, when we have the acute symptoms of the re-experiencing the flashbacks. Interhemisphere, between T3, T4, or T5, T6, are for stabilization, for example, with dissociation, for people who do not experience these acute symptoms. Temporals can be relatively gentler than the parietals, who will evoke more memories. FZ-PZ, one of my favorite protocols, it's connect the front to the back, okay? And again, eyes open or eyes closed, really depend on the client. Sometimes the more challenging one, the client would not be able to do it. So we start with the easier condition for them, and then you will move to it. PDR, posterior dominant rhythm. If you don't have a QEEG to do, you can do a PDR with just 1 or 2 channel device, and you will measure the PDR, which is, we do it in PZ, eyes closed, and to see which in the alpha range, which amplitude is the highest. For adults, it should be in the alpha range. If not, now I had somebody who consulted with me who does not have a PDR in the alpha. He has one in the theta, one in the beta. And I asked the practitioner to record it again to see if there was an issue. Nope. So we need to create a PDR here. Or there's a QAG based, which is also important. I think this is going to be enough. And I know that I went really, really fast throughout this. Now, there are many protocols. And if you would ask 3 people who knows about trauma, you probably would get different suggestions for protocol. It's the good enough. Winnicott was really smart to say it, okay? More likely they will all work. And the reason is because it's a network effect. You can start with different locations, but you will affect the whole network. So there's no one way. There are many, many options. And that's the good news about it. That's also, well, it's good maybe as art or for us clinicians, but for research, maybe sometimes we prefer to know what is going on and what we can exactly do. And I think we covered it until now.
Wonderful. Thank you so much. I will open it up to questions, and I would like to start. I'm just curious if you could elaborate more on what you're looking for and what you do when a person's in the middle of training and they have a flashback. And so, like you mentioned, you're looking at high beta and their muscle tension and their temperature. But like, if we were to kind of live that moment, like, okay, someone's doing a training and they have a flashback, like what are you seeing and what's happening?
You see changes in the EEG, you see physiological changes. And the idea is that it's, again, before I'm going to this protocol who I know that they might evoke memories, we will talk a lot. We will start maybe with temporals. For some people especially, we will start with safer one. This is like temporals. And we will talk a lot about what to do. It's like everything. The best thing is when the client is safe and they have a flashback. I wish we would have a different way, but it's to be with the client to help them go through it. Because when they go through it, they can recreate a different narrative. Like people who were raped, for example, they suddenly remember little details that they did not, which can change their narrative of, I did not do anything. Yes, they tried to move something, they tried to do it. And that would make the difference to create this narrative. And it's not easy when you're there. And you need to know trauma to be with the client when it's happening. Yeah. And again, it's not easy. You see it physically. When they describe it, you hear it. So I would really highly recommend to get to know people with trauma and to go with them. I believe that you can do it, but be ready for it.
Okay, thank you.
And also know how to do self-care with it, because you hear a lot of horrible stories that you don't like. You will want to, like, it's like, how can people do things like this? It's just unbelievable. So there's a lot of self-care about it. Yes.
Yeah, I do. I use T4P4 to do trauma resolution work. The memory processing, where we're redoing the trauma scene, just like you described. And I've been using Seaburn Fisher and Ed, guy in your paper, Ed, forget his last name right now, as a mentor. And they both have coached me into adjusting the reward frequency to mitigate the fear level. So in other words, a person's in a flashback and the fear level is extremely high, then I'll lower that reward frequency down to a point where the fear level becomes manageable for them. So for example, might even lower it down to 0 to 0.5. rather than the PDR. Are you familiar with that?
Yes, I'm familiar with it. And again, I wish there would be more studies about it. It's clinical based. And this is what I said, there are different ways of working. And at some point, if it works for you and your clients, so go with it. I tried it with few clients and it did not work.
Yeah, what's really
So I
amazing.
didn't continue, but it doesn't mean that it doesn't work for everybody. If it works, go with it. And I just wish, that's why we need research. We need random control studies that would show us that this actually works.
Yeah, I'm convinced of it because I've been doing it for a few years now, and had one person who, as a young child, their dog got hit, and they saw the messed up dog on the road, and went into shock. And every time we went into that scene, the shock was so huge that we couldn't do anything with that scene, couldn't touch it. But when I lowered the frequency down to about 3, then the shock was reduced enough that we could work that scene. It was just amazing. So yeah, I hope you or your students can do that kind of research. And the other piece that needs to be researched is the other thing I've found is that I have a client who was drugged many times and then abused under the presence of like a date rape drug, for example. And I found then by doing the opposite, moving the frequency up high into the gamma region, that we can mitigate the drug state and work with that trauma scene. Whereas without it, they're just laid out flat because they're drugged, dizzy and sleepy, and not able to let anything in. So yeah. So please research the frequency variation.
Yes, this is the best platform here. University, let's do all these things. I would love to see. And Sieben Fischen also talks more about T4P4. She talks about the Inion Ridge now a lot, which also she talks about the low frequencies. Again, you try. If it works for you, go with it. I wish somebody would do a systemic research about it.
Me too.
Well, Myron, we should talk, because one of the things I'm considering doing some research on is Mark Smith's version of the slow frequency, bipolar montage, which he calls infraslow fluctuation, which he's published some interesting things on. So, yeah, it's interesting just how many permutations of these different neurofeedback protocols there are, and like you said, Ainat, it seems like everyone has a different kind of style and approach, and there is kind of like a trial and error, use your intuition kind of technique that you just gotta apply and see what works.
Yeah, I don't have the infraslow equipment. If I did, I would try that, because I reach limits even with a 0 to 0.5 reward. And I've talked with Othmer, I think it is, who is doing an infraslow work with trauma and is reporting good results.
And you have the right amplifier and the right electrodes for this slow frequency?
Oh, that's the $1 million question, from a signal processing perspective, but we won't go down that road right now.
Well, but this is actually much less. I think their systems are much less expensive. And if you get special electrodes and special, amplifiers, they claim that they can do it. So, but yes, I want to see research. I mean, I'm much more comfortable doing protocols that have research base. And that's maybe my scientist brain or the fact that I believe in data.
Yeah, me too. I was a chemist for 36 years, so I like data.
So Ainat, going back to the research study that you described, how did you arrive upon the protocol that you used in that particular study, the T4P4 alpha up training? Was that something that Bessel van der Kolk had worked on, or?
No, actually, I mean, I think there is a history, and like every, some protocols we know who are the founders are, alpha theta, we know who to give, right? the acknowledgement for. But T4P4, I think it has different fathers, mothers, or parents, pioneers. I know Seaborn initially was involved in the study, and Ed Hamlin was involved in the study. So that was decided before, but it was the rationale of it, again, was the right limbic system and right temporals that are very active during trauma. And that's one of the things of when you do your neurofeedback protocol, just think about the brain areas, think about what they're doing, which part do you want to treat, and what frequencies you would like to do. So yes, limbic system, right limbic system is very active during it. So let's calm it down. But there was another study that was before the pilot study of Mark Gapen that he published, again, the same group. And that was, it shows that there was no significant difference between T3, T4 and P4, T4. But all of these protocols were independent of symptoms and independent of QEEG. So it's true, but I think perhaps the next level is to try to individualize it and to see what is going on there.
And for people who don't know, she's referring to Seaborn Fisher, who is actually from my hometown, Northampton, Massachusetts. And she's written a fantastic book, Neurofeedback and the Treatment of Developmental Trauma. So Seaborn was one of the people who really helped to get developmental trauma on the map. And if you're interested in exploring this topic more, that book is a really excellent primer with a lot of really great clinical histories. So definitely check that out.
And yes, and if I can talk about Seaborn, it's like one of the main advantages that she also talked about is to incorporate the short sessions of the neurofeedback with therapy. It's just, they just go hand in hand. And that was also a breakthrough.
So when you do short sessions, how often do you have them come into the office to do their 3 to 10 minute session?
The session itself, you know, the time that they're spending with me is an hour and a half or an hour and a half, because it includes a lot. We do it twice a week. Sometimes, you know, if it's too much because a lot is going on or because it's just too much, we do it maybe once a week. But it's similar to the learning process that, again, studies about it, nope. But twice a week is good enough for the forgetting part and for the learning, like how you can accumulate it, and not too much for people to come. And for trauma, yes, you do need time to process it. And that's important.
And also you mentioned earlier on that there was a study about how neurofeedback does more in like 3 months versus 30 years of talk therapy.
This is just what my numbers are. It was just nice numbers. No. There was no study. That was just my numbers. They look nice to me, but it's really shrinking the time. It's like whatever takes in therapy, psychotherapy, a long time, it shrinks it into really short times.
Do you know if there's any research on that, or is that just personal experience?
It's personal experience. Okay. It's one of the things that, you know, even the basics of neurofeedback, there's no research about it. It's amazing. We need so much research about neurofeedback.
What advice would you give to the students who are going to be working on picking a topic and setting up their research?
What advice?
Yeah, how to survive it.
I would welcome anybody who would want to do research to this field. And again, trauma is it's a wide and diverse population. I think try to focus and get a relatively homogeneous population that is accessible for you. This is the most important thing. And yes, do a lot of assessments, subjective, objective, neurophysio markers. and follow the research that was done before. And we're always happy to work together to make it happen. And the reward is amazing. What you get is amazing.
Wonderful. Are there any other questions?
I see that Beverly has her hand raised.
Oh, let's see.
You're muted right now, Beverly.
Okay, let me unmute.
I'm just wondering, is she like a neurologist that's studying the brain and mapping? Because I just got in the middle of it and I was trying to hear everything she was saying.
She is me?
Yeah.
No, I'm
The one
not
that
a
was speaking.
neurologist. I mean,
No,
I'm not a neurologist.
Well, you're saying mapping of the brain and all this. So I was just curious.
This is different. This is analysis that we do when we do brain mapping.
Yeah.
So we want to measure the activity of the brain in several locations, compare them to norm values, do different ways of analysis to see how the brain works, how the individual, like the different placements are, and how they connect, different ways that they connect with each other. And that gives us interesting information. We also do it in different conditions, so we can learn how the brain works. For example, with eyes open, how the person interacts with the world, eyes closed, how the person interacts with himself.
Well, that's the question I have to ask. I have seizures and they do an EEG on me all the time. And I'll tell you what, I can't handle light. The light bothers my eyes so bad. And I can't handle it and it hurts my eyes and I go into seizures all the time. It's a very rare type. They don't have a name for it yet. Some say it's photocautious. Some people say it's sunflower syndrome. And I'm trying to figure out if there is a cure for what I got, because I had it since I was 6 months old.
I mean, again, I'm not a neurologist. I cannot diagnose any of these things, but I would highly recommend you to work with people who work with neurologists also about, do you have epilepsy or it's just seizures?
They say it's epilepsy. I had 3 types and I was beaten and put in a car and I went head first and I got 2 of my seizures are gone. 2 of them are, but I still got the 1. I try to look down instead of up and have my eyes roll back, but I want to do better. I want to help other people out because I want to go for nutrition. That's my dream, is to help people out. And I want to help people in your area, expertise, but I want to better myself first so I know where I'm stepping at and what stepping stone.
So,
because I am so interested in it.
Right. So my email is in the chatting. Send me an email and we can continue talking about it. I can guide you in several directions.
Okay.
Okay.
I appreciate it.
Thank you.
Yeah.
Thank you.
Beverly, send me an email at rwalker2 at Facebook. And I know you joined on late. I can send you the recording of this video as well.
Oh, I would love that. I'm really interested in everything you have to say. I'm always wanting to learn something new.
It's been a fantastic.
That's always good.
I'm sorry if I interrupted you though.
No, that's great. Thank you for your input. And yes, I mean, that's when people go to neurofeedback. I mean, a lot of people should go to neurofeedback, but when other things fail, that's when people will actually go to this domain. And yes, doing analysis of the brain in different ways sometimes can be helpful.
Yeah, that's what I thought.
Well, we are past our time. I just want to send out a very heartfelt gratitude and appreciation for Dr. Rogel. I learned a lot and it was presented in a wonderful manner, and I will have a recording link that I can send out to everyone else. So have a good night and thank you so much for joining us.
Thank you.
And thank you.
Ainat, thanks so much for doing this. This was our first ever. You will forever be canonized as our first ever presenter for the SSPA. So
well, there's something good about it because you don't have anything to compare to, right?
You're the best one we've ever had.
It was by far the best, definitely.
Thank you very much for your time and the information you shared.
Oh, you're welcome, and keep in touch.
Yeah, thank you.
This
Bye-bye.
was wonderful. Now we do
Yeah.
have something wonderful to compare it to. So
Oh.
you're going to be a hard act to follow,
Oops.
and we appreciate you. Thank you.
You're welcome.
All right, have a good
Bye.
night.